I'm going to go over some of the visual field changes that we see in glaucoma. And a lot of them have funny names, but I think the concept is just trying to understand whether the field defect that you're seeing makes sense as a glaucoma or optic nerve visual field change. So visual field loss from glaucoma must respect the nerve fiber layer pattern. You would expect the nerve fibers to come out of the nerve like the spokes of a bicycle, and they sort of do that over here on the nasal side. But on the temporal side, there's this big papillomacular bundle, so the fibers that are going out to the far periphery have to arc over that area. And these fibers, for whatever reason, are often involved in glaucoma. So you get these often arcuate defects. So I'm going to put these little pictures of the nerve fiber layer, even though it makes the slides look kind of busy and junky, up in the corner. So every time you look at a field, you're thinking, does this make sense? Does it fit the nerve fiber layer pattern? Visual field defects, optic nerve visual field defects tend to point back to the blind spot, to the optic nerve, as opposed to neurologic defects, which tend to respect the vertical and tend to point more towards fixation. And they respect the horizontal meridian on the nasal side because this is where this temporal raphe is. Note that there is no such thing on the nasal side of the retina or the temporal visual field. So that's only on the temporal retina nasal visual field that it respects the horizontal. There are lots of kinds of field loss, and I'll go through some of these, all of these, but it's certainly not exhaustive as a list. And some of the shapes that are described as field defects, like Seidel scotomas or nasal steps, are really terms that carry over from manual kinetic perimetry, such as that done with a Goldmann perimeter. And so these terms exist, but they don't really work quite as well in the automated fields. So a really common thing with glaucoma is just depression of the visual field. And while that's common, it is really nonspecific, because if you saw a field like this one on the right, the most likely thing you would imagine is that this patient has a cataract. But you can have glaucoma that just leads to general reduction in sensitivity, as seen in an automated field here or in a manual kinetic field here. As I said, it's difficult to separate this from generalized depression from other causes, especially cataract or meiosis or corneal edema. You can have a focal depression from glaucoma, and that's sometimes easier seen on a kinetic field like this, where all of the isopters are moved in. There are various types of scotomas or blind spots. Seidel scotoma is one of those things that really is a Goldmann kinetic finding, where you get this sort of tadpole shaped extension off of the blind spot. We can have paracentral defects, defects within 10 degrees, such as this defect we see here in the left eye. So it's a superior defect caused by inferotemporal fiber loss. And again, you should look at this and say, does this fit the nerve fiber layer pattern? And the answer is yes, it does. Another patient with paracentral defect, and you can see this notching of the inferior portion of this left optic nerve. And it's a really neat picture that shows the nerve fiber layer defect here, and you can see it also on the OCT. Arcuate defects tend to extend around the central field in this so-called germ area. And here on a manual kinetic field showing the same thing. And again, you look at that and you can make yourself imagine the nerve fiber layer pattern. Nasal steps are where you see the visual field defect lining up with a horizontal meridian. This is a right eye, so it's a defect down here lining up with this horizontal meridian. To be called a nasal step, you need to have one isopter that travels 10 degrees or more along the horizontal, or two isopters that travel more than 5 degrees. We clearly meet that criteria in this patient. You can see that there's also some shallow scotomata here in the germ area down below. Nasal step on a static threshold perimetry, and another in the left eye here of this patient. And one more. So you can see this thinning inferiorly here in this right eye and this corresponding superior peripheral defect. Central loss is possible in glaucoma, but it's very uncommon. And you really need to rule out everything else before you can say that someone has central loss caused by glaucoma. But certainly you can see it, and it does fit the nerve fiber layer pattern right in here if the patient lost temporal optic nerve. And what you would see is the pattern of cupping is that this temporal rim is completely gone. And on OCT testing, that it's very thin temporally here, and the ganglion cell layer is very, very thin as well. As these coalesce, you can end up with a hemifield loss where the entire superior field is missing or the entire inferior field is missing. For ambulation, if you lose both inferior fields, it is very difficult to walk around. If you lost both superior fields, you would be able to ambulate much better, but you might have more difficulty reading because we tend to identify words by looking at the top half more than the bottom half. You can have a temporal wedge. Again, if we look up here, right eye, so if this patient lost a wedge of tissue, of nerve fiber going out this way, it would not respect the horizontal meridian in any way, and you would get this kind of a wedge defect like that. These are relatively uncommon. And then end-stage loss would look like this. So you'd have a central island or a temporal island remaining, or one or the other. So if all you have is a temporal island remaining, then you might have count fingers vision, just terrible vision. If you have only the central island remaining, you might have excellent straight ahead vision on the eye chart, but very, very poor ability to ambulate. So central or temporal island or both. This is a patient who has a central island, and note that this is a size 5 target and a 10-2 exam. So the brightest light in the Humphrey perimeter measuring only the central 10 degrees. So this field is only extending about 2 degrees in this direction. And yet notice the patient has 20/30 vision, but it's like looking through a soda straw. Same idea on a manual kinetic field. This patient only has a field within the central few degrees, but has 20/30 vision. Obviously, progression of field is a sign of glaucoma. This is somebody who you can see has developed in the OCT an area of thinning here and has a small peripheral defect there that corresponds with that area of thinning. This is kind of a horrific field. This was sent to me by Alan Robin. This was not a patient he was managing, but was sent to him. And the provider did fields every year, but never actually looked at them because the pressure was always under 21 millimeters of mercury, just filed them away, and gives us the painful opportunity to look at somebody with unmanaged glaucoma who's gone from a normal field in 2005 to being essentially blind 7 years later, and the other eye, unfortunately, is a mirror image of this. So you can see that this patient developed this little tiny defect here that expanded into an inferior step, and this is all following the nerve fiber layer pattern quite beautifully, unfortunately, showing us what that looks like as it expands, and now starting to lose superior field as well. I'm going to talk a lot about progression in the lecture on how to interpret an automated field, which is lecture 6. So I'm not going to go over much more about progression here. Some other visual field loss terms you'll hear. Some people would call this field a Derringer scotoma because it looks like a little pistol. This is the handle. This is the barrel of the gun. These steep, deep fields losses that come from the blind spot extend through fixation may be more common in patients who have normal pressure glaucoma. We hear a lot about the term bearing of the blind spot, and that is a manual kinetic perimetry term, and a relatively not helpful term. So this is not truly bearing of the blind spot. We would expect, since these isopters are horizontally oval, as they shrink for any reason with age or media opacity, that eventually the isopter will duck around the blind spot like this, and that's pretty normal. So that's really not a sign of disease. If there are multiple isopters that ducked around the blind spot, then that would be true bearing of the blind spot. Or it would also be called an arcuate scotoma, which I think is a better term. Remember, and I've said this a million times, the visual field loss must follow the retinal nerve fiber layer. So this looks like a nasal step right in here, but this doesn't, So this could be a rim artifact, but whatever it is, it doesn't follow the nerve fiber layer pattern, and in this case it turned out to be panretinal photocoagulation. But remember that having glaucoma does not protect you against having neurologic disease or retinal disease. And anything that you see in the visual field that doesn't follow the nerve fiber layer pattern, you need to sort out where that comes from. I just had to throw this field in because sometimes we win. We've looked at all these horrific fields. This is a patient, 1988, age 37. We did a combined cataract, at that time extracap trabeculectomy, in 1989. And here he is in 2014. He's now 63. Pressure of 10 on no medicines, and actually has a better looking field than he did when he was 37. So the key points: optic nerve visual field defects follow the retinal nerve fiber layer pattern. Have I said that enough? They point to the blind spot, and they respect the nasal horizontal meridian, only on the nasal part of the visual field. So I'm not sure that all the little names of the visual fields are all that useful or helpful, but I think the concept of looking at the field and having that nerve fiber layer tattooed in your brain is a useful way of thinking about glaucoma fields.